started. Thank you all for joining us today for today's conversation on clinician wellness and endurance strategies in the COVID-19 era. I am Amy Etzel, Implementation Manager with the BRE Collaborative. The bulk of my work centers around the BRE Collaborative guidelines that are related to integration of behavioral health into primary care and highlighting the relationship between physical and behavioral health. So today's topic is really especially important to me. Before I turn it over to my co-partner on this webinar, Maria Clemes-Ruud with Comagin Health, I wanted to quickly share a relevant quote to our topic today. An empty lantern provides no light. Self-care is the fuel that allows your light to shine brightly. Author unknown. Just a reminder for you all doing such important work in these strange times to remember to also take care of yourselves so that you can continue to do this important work. Okay, Maria, take it away.
Thanks, Amy. Hi, everyone. My name is Maria Clemes-Ruud. I'm an improvement advisor with Comagin Health, formerly Qualis Health, and I am a licensed mental health counselor. Comagin Health is leading a CMS-funded initiative, and very briefly, the five bold aims of our initiative are increasing patient safety, improving quality of long-term and post-acute care facilities, preventing and managing diabetes, heart disease, and kidney disease, increasing quality of care transition and decreasing opioid misuse, and improving behavioral health outcomes. Of course, all of this is through the lens right now of rapid response with our COVID situation. I'm grateful to have the opportunity to collaborate with the BRE for this conversation, and the meetings that we've had previously, we've all really feel strongly we want this to be a conversation. I hope the themes we discuss will allow all of us some space to care for ourselves and others during a very challenging time, professionally and personally. A few housekeeping notes before we begin. Our webinar is being recorded and slides will be available and sent out to all participants after the event. We've allowed plenty of time at the end of our three presentations for Q&A, and we will track those in the Q&A box. So if you think of things as the presenters are speaking, please put your thoughts in the Q&A box and I will be tracking those. Amy will be tracking kind of logistics if we have any technical issues. We encourage you to use that box, don't be shy. And then if you want to continue the conversation or want a phone call or to continue via email, please don't hesitate to reach out to us. I'd like to take a minute to introduce Trevor, and Trevor will introduce members of his strike team. Thanks so much, Trevor, for being with us. Trevor Covington is the Mental and Behavioral Health Response Coordinator with the Division of Emergency Preparedness and Response with the Washington State Department of Health. And take it away.
Yeah, absolutely. Great job, by the way, in doing that in one breath. It took me a little while to be able to pull that off myself. So thanks so much for that introduction. Glad to be here. Really excited to talk to folks today. So I got introduced by Maria. Thank you so much. With me is one of my co-leads of the Behavioral Health Strike Team, and that's our team of psychologists, psychiatrists, and therapists with a background in disaster response, disaster psychology. Tona, if you wouldn't mind introducing yourself real quick.
Not at all. Thank you for allowing us to be here today. I am Tona McGuire. I'm a clinical psychologist by training, and my specialty throughout my career has been in pediatric psychology, so have spent a lot of time working with children and families dealing with chronic and acute illness, including at Children's and at the Fred Hutch Cancer Research Center. I've been involved in disaster response for about 12 years, and currently I'm activated with DOH as the Behavioral Health Strike Team co-lead.
Great, thanks, Tona. I will pull up our presentation real quick. For a little bit of my background is I do that. I really kind of come at these things from a disaster response perspective. Certainly have some interfaces with behavioral health. Obviously, I've been involved with that across quite a few disasters, but really for all of us, COVID-19 is a whole different thing, right? So really at the start of this, we decided we wanted to have a clear vision of what the impacts would be. So that's going to be a little bit of what I share with you. After that, Tona is going to share some more in-depth information about impacts for both the healthcare and behavioral health workforce. And then we'll talk about some of the things leaders and organizations can do to build resilience, right? Looking at that as a key operational strategy to make sure we can keep providing services to the folks that need it well through this pandemic. So with that in mind, we're going to go ahead and jump right in. So I will say all the information that I'm sharing with you is available in our forecast. We'll provide some links at the end if you want to do a deep dive, but I want to give some high-level points for you to walk away with today. The first one is we are expecting upwards of 3 million Washingtonians will likely experience clinically significant behavioral health symptoms in the next 3 to 6 months. We know compared to other disasters, this is going to look more closely to things like depression, anxiety, and acute stress. Right now, the numbers that you see in parentheses right there are from the Census Bureau data. And in Washington State, that survey showing about 1.9 million individuals are showing symptoms of depression and 1.2 million are showing symptoms of anxiety. So while we expect there's some degree of comorbidity, we're already creeping up to that 3 million number that we forecasted back in April. We do have some concerns around PTSD. We do expect it to be less common than most disasters. In particular, populations we're concerned about are individuals that might be exposed to traumatic events. So you kind of look at it like an exposure model. Tona will talk a little bit about some of the risks for both the healthcare and behavioral health workforce, but then also in particular, individuals coming off of post-event critical care we're concerned about. There's reasonably high rates of PTSD in that population as well. The key thing to keep in mind is these symptoms will shift over time. In particular, if there is more disease outbreaks in communities, we can expect it to shift away from depression and anxiety to probably a lot more PTSD-like symptoms. The other thing we're concerned about is substance use. We know that goes hand in hand with mental health related challenges. Roughly 50% of individuals who experience a behavioral health diagnosis will develop a substance use related disorder and vice versa. Individual research on this pandemic shows approximately 20% of individuals could struggle with alcohol use, but less than 0.5% of those will likely be new acute cases. What that tells us is individuals who are already struggling with acute use will likely struggle even harder. And that's a common theme you'll find with a lot of this. Not only will there be some individuals who have never struggled before coming into our system, but also folks that are already struggling will have a harder time, some of them across the board. With that in mind, we're seeing some of these trends already in the tax revenue data, which is one of the data points we looked at. Compared to 2019, May 2020 data for both marijuana and liquor shows significant increases. So about 44% and 31% respectively compared to 2019. Unfortunately, we also know domestic violence does tend to increase post-disaster. This is true for COVID-19 as well. While we've seen about a 26% decrease in select other offenses, we've seen about a 17% increase in domestic violence compared to 2019. It varies from month to month, but that's about the average we've seen. And we believe the true number of cases is likely significantly higher because there's less opportunities to essentially catch instances of it or for folks to ask for help. Kind of the last big part before I turn over to Tona is a little bit of an overview of the psychological phases of disaster. We do know those come in phases, they're predictable, there's a model for this, and they tend to peak about 6 to 9 months post-outbreak. They follow essentially when the disease outbreak and mitigation activities start in the communities, and that's kind of the timeline. That's going to look different from community to community, but in average will present some overall trends for Washington. I do want to emphasize these are normal reactions to abnormal circumstances, and it's important people know that. It's abnormal that you might not be able to remember what date it is. It's completely normal that Tuesday might feel like a really long week already. What are some other ones we've talked about as a group? Even just reporting out what you did for a day, it's normal to have to go back and be like, what did I actually do for the day? These are normal reactions to kind of some of the stress and chronic challenges we've been dealing with. So this is a really important slide for people to be familiar with. What this does is it captures the various phases of disaster over time. I won't dive into it in depth because we don't have a lot of time today, but I do recommend you check out our forecast for a little bit more information. The big takeaway is the circle there. So we're moving into the disillusionment period where we see a lot more people acting out and acting in. So that might be increased aggression, law breaking, substance use. Acting in might be everything from blunted emotional expression to voluntary withdrawal. Our concern in particular is the disillusionment period for Washington. That's going to be September through December. And that's where we think kind of symptoms of despair might peak. So that is increased depression, potential suicidal ideation, and those sorts of topics. The last thing I'll share before I turn it over to Tona is a little bit of an overlay of what the interaction between disease activity and behavioral health impacts looks like. So I want to be clear, this is not an epidemiological forecast. This is just to visually capture the relationship. And the two key things I'll highlight for you is one, we do expect any additional disease activity to be hard for the communities it's impacting. The idea of like, hey, we had time to prepare for this. I thought we had this under control. What's going on? We're having to pull back the things that we already dealt with before, so increased restrictions, those sorts of things. So we do expect that to be harder. And in addition, we expect the behavioral health impacts to highly correlate. And if there is a large fall peak, which has happened in other pandemics, we do expect us to stay in that disillusionment period for a longer period of time. With that in mind, I'll turn it over to Tona.
Thanks, Trevor. So knowing what's ahead of us and planning for that, we can look behind to get some idea of what the impact on healthcare providers has been from the very beginning of the pandemic. These numbers come from really early research, mostly located in Asia, but showing, pretty astonishing numbers of healthcare workers experiencing depression, anxiety, sleep disturbance, and distress. In addition to these stress symptoms, we want to recognize the risk of moral injury as well for our providers here in Washington State. So in the spring, we came extremely close to crisis standards of care a number of times with the huge patient surge and a lot of other factors. And that puts healthcare workers at further risk due to the fact that they're dealing with altered standards of care, as well as high death rates. And often they're the only conduit to families and the only support and witness to the dying. So that's another additional layer. Next slide, please. When we consider the impact on responders, we also want to consider the impact on responder families. This comes again out of the disaster and disaster responder literature that shows that basically whatever the impact is on the parents, it tends to trickle down to the children. And so we want to be especially cognizant of viewing healthcare responders and providers as kind of a holistic system. It's a little circle that has waves going out. Next slide, please. I just want to highlight that we have recently released our behavioral health toolbox for families, and this comes out of a mini request for, please can I have something a little bit more substantive than a tip sheet. And so in addition to the things that are on the slide, the toolbox discusses the impact of disasters on children, how to mitigate that, how to manage behaviors, improve communication and positive behaviors, all of those things. In addition, it's got sections on guidance for sleep in children and teens, which is an issue for all of us, frankly. And then an addendum that specific issues related to children on the autism spectrum. Next. And so there is no research that we could find anyway on the COVID impacts on behavioral health providers, but there's a lot of anecdotal information that's coming out in media reports and from my colleagues talking about the impact on them as well. An increase in acuity for their current patients who initially, as happens in disasters, got a little bit better in the beginning. But now are getting worse. And so increased suicidal ideation and risk for that. Just a surge in patients in general requesting services because of COVID stresses. Working with patients around the complex grief due to the really unusual circumstances surrounding COVID deaths. Fatigue, as we're all experiencing due to the length of time for this disaster. And then that rapid, all of a sudden, you have to shift your entire practice to telepsychology, which was a new model for many providers. So I'm hoping that someone will be doing some more in-depth and precise surveys of behavioral health providers because I believe they're also an at-risk provider population. Next slide, please. So with an anticipated second wave or more, we've turned our attention to an opportunity to try to create some behavioral health depth and resiliency, our group is prioritizing in particular healthcare organizations and healthcare workers. You should know that planning for scarce behavioral health resources in particular has been going on for years. Fortunately, Washington State has been ahead of the curve in overall disaster preparation, particularly in with regard to healthcare resources. And so the Disaster Clinical Advisory Committee, which works under the auspices of the Northwest Healthcare Response Network, has put together a series of recommendations. And this slide shows the recommendations that came out of the discussion and subject matter expertise input into what do healthcare organizations need in order to have behavioral health resiliency when resources are very scarce. In the highlighted section, you see the recommendation for training healthcare workers in more in-depth disaster behavioral health principles and tools. And what that will allow them to do, or at least what we hope that will allow them to do, is to provide educated support to their colleagues and monitoring for their colleagues. Someone like me can get called down to a particular unit or an event if they're having a hard time, but I won't know what's going on. I won't have a baseline like the health providers who are already embedded in the system. Next slide, please. So the curriculum that we're using is the health support team curriculum, which comes out of disaster response internationally and locally. And I'll explain a little bit more about how that works. Next slide, please. So we've been training the health support team curriculum for a few months now to organizational leaders within the Department of Health, clinic staff, public health staff, and others. And we know that from research that simply providing education about common responses to disaster is in and of itself protective. It's one of the things that reduce the stress level early on for healthcare workers in China, for example. And again, as I mentioned in my previous slide, it equips colleagues and team leads who are the ones who are best equipped to evaluate and provide early intervention for their struggling peers. Next slide, please. So this is the process for the team training. It starts with education on disaster impact, what's normal in an abnormal situation. We emphasize a lot of training in effective communication and active listening, identifying and developing referral sources if you see significant mental health or substance use issues, de-escalation tools, dealing with grief. And then it goes on to teach tools to assist in managing the common stress responses for, the acute stress responses for everybody who goes through a disaster. And it comes out of the psychological literature, so it's evidence-based interventions that are relatively easy to teach, can be learned by just about anybody. You can find them on the internet. You can find all kinds of manuals on Amazon. But we teach those because reducing symptoms, we think, is a very helpful strategy, particularly early on. And then it focuses a lot on self-care, which is a critical piece of all of this. Once someone is trained, they can train it forward to their colleagues, and it becomes hopefully embedded within the system and a support. For training individual healthcare workers on risk management and building coping and resiliency skills, we're offering a tool called SciStart Responder. This training and resource has been offered to the Department of Health by the developer, Dr. Merritt Schreiber, who is a well-known disaster psychologist and has put this together to train out a number of disaster responders, first responders, as a way of protecting them against the stress of what goes on. Next slide. So we want to go over with our trainees in SciStart what the research shows, what the risks are, how to monitor, and then developing your personal mitigating strategies, if you will, because it's not, none of this is a one-size-fits-all. What is extremely stressful for me may not be stressful at all for Trevor, and vice versa. What works for me in coping may not work for him. Next slide, please. So this is the continuum of risk and resilience in disasters. On the left, the big circle, you can see that transitory distress response. Upwards of 90% of us are experiencing that right now, one or the other of these. The red circle shows the incidence, new incidence disorders. So these are disorders that weren't present originally, that's not getting worse, but are actually new for the population at large, and then for healthcare providers. lower than everybody else for a variety of factors, but we want to protect those 10 to 20%. Next slide, please. So SciStart Responder helps understand what risk factors are. The symptoms that we all experience are not predictive, but exposure to certain events is very predictive of a risk of post-traumatic stress disorder and depression. Next. So when people are trained to monitor themselves, it's akin to if you work in a radiation environment. You monitor your badge, which indicates when you're at risk. Self-triage acts as kind of your personal stress dosimeter. Next slide, please. And then after teaching people how to monitor and track this exposure, the training explores personal coping strategies, teaching them to essentially put on their emotional PPE, if you will, and then directs them in a stepped approach to self-care, which might include apps like Headspace, recommendations for that they access employee assistance programs and professional services. All of the self-triage information can only be seen by the individual, who can then track their risk by the type of exposure as well as cumulative exposure. Next slide, please. The ultimate goal of this is to flatten the psychological curve by raising the awareness of risk, implementing mitigation tools, hopefully avoiding the development of new disorders. Research on adults has certainly shown that early intervention can interrupt that pathway to PTSD and increase the potential for a resiliency outcome. Next slide, please. The other thing about SciStart Responder is that for managers and systems, certain people within an organization can be trained up on how to access non-identifiable and aggregated information for their system, for their hospital system, their organization. And the aggregated information can inform them in real time what the stress levels are and the exposure levels of their staff. It can be organized by location, it can be organized by type of employee, and we think that this will allow organizations and managers to implement that increased support in a timely manner. So Trevor, I think this is you.
Yep, wonderful. Sorry, just working through the interface. Thank you, Tona. So we wanted to present kind of the high-level impacts, how this might impact healthcare and behavioral health providers, and some resources. Like Tona mentioned, just kind of recap, one resource that isn't on this page is the Behavioral Health Toolbox for Families. I think you have kids, right? I think it's a great resource, in particular, helping don that PPE for not only you, but for your family, as well as the analogy Tona laid out. The health support team training, we're making available to both healthcare and behavioral health providers. It's great to infuse that with kind of some of the natural helpers in the team. Like Tona mentioned, there's a train the trainer component as well. We are offering SciStart Responder, in particular to the healthcare, frontline healthcare, due to the generosity of Dr. Tripp Schreiber, like Tona mentioned previously. So that's a great resource we've just barely started to roll out. In addition, I just want to highlight that's available to the next couple links I'll share. There's a behavioral health group impact reference guide that goes through unique at-risk occupations. In particular, it highlights healthcare and behavioral health. It provides an overview of what the unique challenges are and what are some interventions both leaders and individuals can do. So that's kind of a great in-depth guide if you want to reference. And then we do have a nice back sheet as if you're just kind of looking for something to hand out or pass them around in a newsletter as well. And that's the Coping During COVID-19 for Emergency and Healthcare Professionals. So all those are available. There's a ton of information out there, and we're really excited to be able to provide these resources out to folks. Lastly, and we'll share this out as well, you can access the resources we mentioned, including the forecast and situational reports on our website. And in addition, there's a whole bunch of mental health resources available through the state. Lastly, I'd be remiss if I didn't promote the Washington Listens line. It's a free line available to everyone in Washington looking for a warm support line for assistance with COVID-19 mental health. And it's anonymous. There isn't a limit on the call line. So we're trying to promote that not only for people you might serve, but for your organizations or even you yourself. So with that in mind, thank you so much. We're glad to be here and happy to be part of the conversation. We'll turn it back over to you.
Thank you so much, Trevor. I get to introduce Wendy. I'm honored to introduce Wendy Sisk, licensed mental health counselor and CEO of Peninsula Behavioral Health for the past 4 years. Wendy has over 20 years of community behavioral health experience with a focus on geriatrics and crisis intervention. and she is dedicated to ensuring all community members have access to quality behavioral health care. If you know Wendy, you know that she has a passion for advocacy of others, and she provides an assertive voice. That means that she often will say what everybody else is thinking. And, and I so appreciate that. It's very liberating. And the leadership to deliver mental health care to community members in Clallam County on the beautiful Olympic Peninsula. Thank you, Wendy, for taking the time to be with us today.
Thanks, Maria, and thanks, Maria and Amy, for inviting me today. About 6 weeks ago, Maria and Amy reached out and said, hey, do you want to come to this webinar and talk about self-care? And interestingly, our webinar got bumped because there was a competing time slot for a webinar around clinician self-care. And over the next few weeks, we saw a lot of resources coming out and talking about self-care. So I'll talk a little bit about that today. But I wanted to talk too about what we've done organizationally to support our staff through this challenging time. Some of our lessons learned. And it's been interesting as behavioral health providers. I think that we often think our staff should be more put together than our patient population, and sometimes that's true and sometimes it's not. And what we've found is that people have just needed a really high level of support to manage their own personal distress, whether it had to do with family situations or people they know becoming ill. And we live in a small rural community where we all know each other, and I know that there's some other providers online today from our community. And it's a really challenging time for us. And behavioral health providers, I think across the state, didn't know whether or not at the outset of this pandemic, whether or not our state was going to classify us as essential workers. It was all clear to us that grocery stores had to stay open. It was clear to us that healthcare providers had to maintain access for patients. But I think a lot of behavioral health clinicians thought, they were going to be asked to be locked down as well. And it created some really unique challenges in terms of managing staff. And our team really put our heads together and took a whole leadership approach to any decision-making around COVID-19. We included our supervisors so that we had the voices of every team as we made decisions about how to move forward. Very early on, we recognized that this was going to be a marathon, not a sprint. I think, again, many of our staff thought that this was going to be really short time limited. By the end of summer, we'd be back to normal and going about business as usual. And as we all know today, that just wasn't a realistic expectation. And so part of our job as leaders in our organization, we felt it's been really imperative to be communicating actively with staff. I think one of the things that drives anxiety most with our staff, and I imagine your staff as well, is the not knowing. So the big unknown right now has been around whether or not schools are going to be in operation. And we have many staff who are parents, and that anxiety of not knowing how to manage their children's homeschool situation, or are they going to go to school part-time, has been incredibly challenging. And we've tried to be really flexible. Our organization was able to, for a short period of time, have staff transitioning, working half-time from home and half-time from the office. And that really, I think, helped recharge our staff. So as we're looking at things we can do as we roll forward, we're trying to be creative and flexible about hours and work schedules, because we recognize that it's imperative that our staff are here to do the work that they do, but at the same time, they have responsibilities outside. And sometimes it's absolutely infeasible for us to be flexible, but we are working really hard to do our best. We're encouraging self-care, and I'll say just a few words about that. We're encouraging people to use their vacation, and I'm hearing a lot of providers in my network talking about, we can't let people take time off because we need to have them here. But I challenge you that if you don't allow your staff to find some time away from the workplace to manage their own needs, that they're not going to be here when you need them most as this continues to escalate as we roll into the fall and winter. Encourage staff to take that 5-minute walk, get out of the building, get a breath of fresh air. Whenever possible, be conscious of the people who report directly to you, what other stressors are going on in their life. Not that you can always resolve it, but you need to be sensitive to that, especially at this point. And be realistic of your expectations about what they can and can't do. One of the interesting things with the transition to telehealth is, I don't know how many of you are doing Zoom meetings all day like I am, but you get televideo fatigue. And that's been a new experience for particularly our therapists. If they have too many televideo sessions in a day, the quality of care that they provide by the end of the day is diminished. So we've reset our expectations of how much care we expect each provider to provide in the course of the day. Again, trying to be realistic that this is a marathon, not a sprint, and we don't just have to provide care today, but we have to be here through the long haul. Some of the other things that we've found to be really important is sharing stories of successes. In behavioral health, success often happens over a very long period of time. And, you know, if you think about from the healthcare standpoint, somebody who comes in with a chronic diabetic issue that's been really bad for a long time, it's sometimes going to take you months or years to see real improvement in the quality of that person's health when they're really working the program. And that's very true in behavioral health. So we're really trying to take moments and step back and say, okay, so what's a success that we saw today, and share those success stories amongst ourselves. And we recently had a therapist on a televideo session. Her client started having chest pains. She stayed online with that client, got another staff person to get medics out to the home, and was advised that if he had not made it to the ER at that time, we probably would have lost him. So we're really taking time to look at what is our mission and what are we doing that's impactful, and forcing ourselves to remember why we're doing this work and why it makes a difference. We're also trying to make things fun. It's really stressful when, you know, there's all of this stuff that you can't control. So as an employer, we've worked hard. We have a wagon that we bring around, and we turn on popsicles, ice cream truck music, and sometimes we deliver popsicles on a hot day, or we have passed out chocolate bars at the end of a really hard week. And it's sometimes it's those small things that add up to make the biggest difference for staff, to let them know that you notice, that you care. Thank you notes. We've encouraged our supervisors to periodically drop a thank you note to their staff. We had a supervisor who hung, you know, thanks for being amazing type signs on everybody's doors in her hallway. And I had to tell you, that was early in COVID, and I would say at least 75% of those signs are still up, which tells me that they were meaningful to those staff. So, you know, we really want to encourage you to communicate with your staff as much as possible about what's going on in the big picture, because what drives anxiety more than anything is that unknown. So communicate, communicate, communicate. And I know it's hard, and sometimes I know it's hard for me to know what's helpful to say, but recognize that everybody's struggling with this in different ways. And we have some staff who think this whole COVID thing's not a really big deal. And now we have a bunch of staff at home on quarantine because of that. And we have staff who are taking it very serious, who are very high risk themselves. So, you know, really, again, trying to meet people where they're at and providing as much information and communication. The other thing I want to share, Tona and Trevor were kind of a hard act to follow. They had some great data, and one of the data pieces that really stands out to me is that our marijuana tax revenues have increased by 44%. And what I want to also remember, all of you who are healthcare providers, is that use of marijuana decreases our ability to manage symptoms of anxiety. And so with that increase in use, we can expect a community-wide increase in our anxiety as that marijuana depletes the neurotransmitters that help us manage anxiety. So, you know, we have a long haul ahead of us. Encourage people to make healthy choices. As an employer, be as flexible and creative as you can in terms of meeting needs, and communicate, 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 because that is how we're all going to get through this together. And it's not going to be easy, but we have an incredibly resilient staff. So watch for signs of burnout, encourage that self-care, and help people in whatever small ways you can to show that you support them, because that adds up to large dividends in the long run. Thank you.
Great. Thank you so much, Wendy. That was really, really great. Thank you for being part of our conversation today. I now have the pleasure to introduce our primary care provider and representative on this discussion, Dr. Tony Butrill. Dr. Butrill has lived and worked in Leavenworth for the last 17 years. He works at a critical access hospital where he covers the emergency room, works in the hospital, and provides endoscopy services in addition to covering the clinic. He is a past president of the Washington Academy of Family Physicians, is a current alternate delegate to the American Academy of Family Physicians from the East Side, and currently chairs the Primary Care Investment Task Force. Thank you so much for spending time with us today, Dr. Butrill.
Yes, thank you, Amy. I'm really appreciative for this opportunity and for everybody who's joining in today and the comments from the previous panelists. I wish we were all in the same room together. Sometimes these can be difficult discussions in this format, and I hope everybody is staying safe and doing well. As Amy mentioned, I'm a family physician in a small town, have been my whole career, and that's the perspective I'm going to bring, is speaking not just for myself, but in broader terms about the primary care experience. And I'm speaking mostly to clinic directors and managers and policymakers that might be in a position to influence support for the primary care team. So, you know, at baseline, if you ask any primary care physician what they want professionally, you'll get some variation of, I want to be able to do everything I can for my patient to take good care of them, and I want to get home in time for dinner. I think those are the two things that stand out on any day as we start our day. That's what we want. The problem is even at baseline, the current system has not been great at supporting us in that. There's a lot of variation depending on where you work, but in general, nationwide and in Washington state, about 5 cents of every healthcare dollar goes towards primary care. And the best studies and the best examples show us that 12 to 15% is about right. So we're less than half where we should be. And what that translates to is if you don't have enough support, you tend not to have folks around helping you out. That means that really important patient care tasks that somebody else could be doing, things like, refills and medication reconciliation, longitudinal and population management to make sure chronic diseases are cared for, managing those high-risk patients that just need that phone call and a check-in every once in a while, triage, prior authorizations, coordinating refills, making sure transitions from ER visits and hospitals go well, preventive services get done. We've seen studies that show that if we just did every preventive service the way it's recommended to be done, we would spend over 7 hours a day just doing that part of our work. So when those folks aren't around, it cuts into both of those things. We aren't able to take as good a care of patients because they tend not to get done, or we try to do them ourselves and we just are, in the office until very, very late. We often lack then the partners in our care that we need, folks like integrated behavioral health and social services, pharmacists, nutritionists, all those professionals that by doing the things they do well can really extend the care available to our patients. And so what that means at the end of the day, even at baseline, like I said, is that both of those things that are important to us just don't happen. We can't take as good a care of patients as we want, and we don't get home in time for dinner. If we make it home in time for dinner, it often means we have to spend a couple hours after dinner finishing up our charts. And again, that's just at baseline. There was a survey that was published last August that said that 79% of primary care physicians are experiencing symptoms of burnout. And that's it's just about half again as much as the specialists that were surveyed. So 4 out of 5 showing symptoms of burnout. And again, this was before COVID-19. So in a pandemic, what was hard has just gotten harder because now we've got the fear of getting infected, and do we have adequate PPE? Are the protocols in place to ensure our safety as well as the safety of our patients? We're practicing in more socially isolated fashion, which can be tough. And there's all that uncertainty that's been referred to in the shifting terrain and changing protocols and trying to get used to different kinds of practice, telephone visits and virtual visits, and are they working? And as has been mentioned, our patients just seem sicker, right? There's much more depression and anxiety. I've had a suicide recently in my practice, which is not customary, multiple hospital admissions related to alcohol and spousal abuse. And also, I've had more heart attacks in my patients, heart failure. I think that patients just aren't getting the care they need, or they're staying at home, not taking care of themselves, or they've got stress hormones running through their system. But for whatever reason, patients just seem sicker, which just contributes to that care fatigue in our primary care teams. And we've also noticed that the marginalized part of our patient panels are disproportionately impacted. The wealthy people tend to get the care they need and seem to be doing well, but the folks who don't have computers or Wi-Fi or who've lost their job and their insurance, we know they're out there and we know they're struggling, and it's really hard to connect with them. There's tremendous financial strain into primary care practices. Today, 20% of primary care practices say they may not be viable for another 4 weeks. We've had reduced payments, increased cost of care. And because of that, then we've cut staff, which means we have even fewer people to take care of our patients now that it's getting busier. The politics of masks and stuff seems to intersect in our office all the time, which can be tough. And of course, we've all got the same personal adjustments everybody else is dealing with in terms of, you know, how do we take care of our kids as the school year is starting and they have to be at home online. So if people aren't aware of the Larry Green Center Primary Care Survey, it's published by the Primary Care Collaborative. Every week they survey primary care physicians, and it's a really fascinating snapshot at how our community is doing. And they've got a whole list of quotes that people send in along with their survey results. And it's really fascinating because for everybody, their experience is different and what they're suffering from is different. But in their last summary, they said, the lack of substantial policy response by public and private sector leaders and a persistent dire new normal pose a credible threat to potential collapse of the U.S. primary care system and specifically of independent practices. And 4 out of 5 in that study said that their practice strain right now is worse than it was in March. So I want to pause for a second. It's funny, my wife saw my notes on the counter this morning and said, geez, Tony, it's kind of negative. And I want to address that. I think that I and the doctors that I work with and the doctors I know, we really love what we do. And I don't want you to think, you know, and I think for the most part, we're doing okay. But I just want to present an idea of why we do struggle in some areas. And I also want to be very clear that everybody is struggling right now. Heavens, the small business owners in our community and the teachers and stuff. So, but let's talk about what we do. And I think some general rules. One is get to know your providers because everybody's got different things that they might be struggling with. And unless you touch bases with them frequently and really find out, are they doing okay? And if they're not, why not? And if they need more support, how can you get that support to them? If you can express understanding and empathy and appreciation and communicate, I think policies and protocols, they need to be communicated routinely and in clear, concise fashion. And importantly, we need to have it clear who we talk to if we have questions or concerns, a clear point person in terms of how we interact with these policies that are changing all the time. That same survey last summer that I talked about asked the same doctors, well, what can be done to alleviate burnout? And it was interesting. The only responses that got over 50% were those that had to do with either more time away from practice or more practice support. So increased staff support, that was 66%, so that would help me. Mandatory vacation or half days, that would help me. That was 57%, and reduced patient volume. So again, it gets back to doing all we can for our patients and then having more time at home. Less than 10%, only 8% said seminars, education, team building exercises, things like that. I think along the way, we've become conditioned that if we're feeling stressed, it's kind of our fault. We can kind of yoga our way through it. But I think when you start talking to folks, it really has to do with being aware of why they're struggling, what you can do to support them in the work they want to do in terms of taking care of patients, and then being able to provide that support. So, and with that, it's so funny. I apologize. I hope you can still see me. My wife is actually just calling me now. She must have heard me. So I am done. Thank you.
Thank you, Tony. Really appreciate those words. I'm going to turn it back to Maria to facilitate our Q&A discussion.
All right. I so appreciate, Tony, your perspective. And I think that I really like how you framed, you know, really fully transparent about our current state, and that you're not meaning to be negative. It's just what we're all living in. And I think more especially for a primary care doc who's seeing, as you said, chronic issues, or you know, your patient's sicker and maybe not having the resources, just doing everything you can to try to help, and just feeling like you know, already last August that percentage was so high on burnout. What would it possibly be now? So I guess the most interesting thing to me, Tona, I'm interested in the idea of voluntary withdrawal. I think that's so interesting, especially we all know that healthcare workers, behavioral health workers, we all feel like, oh, I can handle anything. And we may not, we're really, really good at helping others, but we may not be as aware or as able to help ourselves, or to be able to say, let somebody help us. So I'm interested in that concept of voluntary withdrawal. I can relate to that, and I see it in myself. But I'm wondering what your experience has been, and then how do we recognize that in our colleagues, especially since we're also isolated from each other.
I wasn't clear. Was that question directed at me or to Tony?
That was to Tona.
Okay.
But I'm happy to have anybody that wants to speak to that. Before
I step in it, yeah. No, I think people have different styles, you know, as you know, personality styles. So for me, as I think about myself as kind of an Olympic level introvert, some parts of COVID have been okay for me, not having to have quite so much draining interaction with people. But I do think that there is a point at which people's styles are, as Trevor mentioned, either to act out or act in. And that acting in is just the much more passive approach to that. You know, I just don't have the energy for this. I don't want to interact with anybody else. I don't want to talk to anybody. I know about these resources. I choose not to participate in those because I'm just fatigued. So there's that aspect of it where the impact of the disaster is weighing on us, and our particular styles kind of come out at that point in time. And then I think some of the intentional withdrawal is probably a protective measure for some folks, that it really is more of a planned withdrawal, not so much a passive pulling back, but I need a bubble around me for a while. And that's not such a bad thing, and not something that we should be discouraging particularly.
Thank you. And Tona, Mary Beth wanted me to ask you what the symptoms are that we are all experiencing, and the border. Mary Beth, go ahead, and why don't you ask it?
If you could, hi there, if you could kind of comment on the symptoms that we're all experiencing and what to look out for. What are the red flags when it becomes something where people really should seek help?
Sure.
You know, there are times we withdraw when we really shouldn't, but I thought there was some stuff in your presentation that you went over kind of quickly that maybe you could revisit about those symptoms.
Yeah, the common symptoms are kind of acute stress symptoms. So sleeping difficulties, either sleeping too much or not sleeping enough, waking up in the middle of the night. A lot of people with COVID, for some reason, have been reporting weird dreams. So a common thing, and also probably a sign of stress. One of the big things is somatic symptoms as a stress marker. So stomach aches, headaches, extreme fatigue, I just don't feel good, pain, that sort of overall, I'm not feeling good. And back before COVID, a lot of these stress somatic responses would have shown up in a primary care setting as one of the reasons for an appointment. I think people have been avoiding clinics, but there are all of those. Symptoms of feeling down, symptoms that are depression-like, but maybe not depression, and a lot of symptoms of anxiety. What's going to happen to my job? What if I get sick? I don't know if I can keep managing all of this. And I think for individuals, they really will know kind of where their breaking point is. Some of us are better at finding ways of being resilient and coping. Others of us struggle a little bit. But for each of us, I think we know when we've kind of edged into that, you know, I haven't had a shower in a week. I've not reached out to any of my friends. I'm in work meetings, you know, I'm just not showing up. Those kinds of things would be things that would be concerning to me.
And one of the participants talked about, I guess for everybody on the panel, the comment is it's a struggle to get individuals who need specialized care to go to the provider's office. they may be medically compromised. I think this would be an opportunity for creative problem solving where, you know, that kind of mental cycle of, I don't want to go where I may be in danger. And so the lack of insight that I may be putting myself at danger by not going, but also the idea, especially, you know, where mental health resources or behavioral health providers, case managers, as well as, you know, neighbors, communities can help patients in different ways, be it following them to the clinic, checking on them before they go, checking on them after they get home, ways that people are less isolated but yet have that support. Anybody from the panel have a comment on that?
I know in our practice, we've sent letters to our patients just encouraging them to come in and highlighting some of the protocols we've put in place to ensure their safety. We've videotaped messages for our website. And then importantly, within each practice, we kind of know the patients are at highest risk, and just a phone call can make a huge, huge difference.
I would agree with Tony on that. And, you know, in behavioral health, we sometimes have a little bit more flexibility to do some outreach. Our community is fortunate enough that we have a community paramedicine program where we can actually tap a firefighter or paramedic to go out and do an in-home visit with that person. So, you know, being creative with your community resources that might be available to proactively reach out to those highest risk patients is imperative right now. But educating too on the safety of coming into the clinic and how you're going to protect them. And more often than not, that personal phone call makes a huge difference in that patient's comfort level in walking into the clinic.
There's a question, I think, for the whole panel, and that is a rise in has there been a rise in suicide rates in both the providers and patients? And I think it goes along the same lines of either suicidal ideation and or, you know, suicidal behavior. What are people's thoughts about that, or what have you seen?
It's not parsed out by provider or patient that I've seen. At least I haven't seen any data that does that. But we know that there's a pretty sharp little uptick in suicidal ideation and presentation to emergency departments for suicidal thinking or intent. And a lesser uptick in terms of actual completed suicides. But the suicidal ideation seems to be from younger folks. So teenagers and early adults are the ones that are presenting in more substantive, you know, numbers to the EDs that I'm aware of.
I also heard that caregivers were also at higher rates right now.
Yeah.
We have another question. How do you help a provider who is acting out? Perhaps they're short with the staff, they're not returning phone calls, but won't acknowledge that they're struggling. How do you offer to help if they don't feel like they have an issue? Which kind of goes with that, I don't need help, you know, personality that many of us have, but I can handle it myself.
That's actually one of the scenarios that we tackle in the health support team training, because it's a very hard conversation to have that with a peer. You know, those of us who would be comfortable approaching a patient and saying, you know, I'm concerned about this. It's a whole nother thing when you're talking to a colleague. And I think this is where having some skills in communication, having some skills in initiating those conversations and sort of instigating that back and forth in a non-judgmental and confrontive way can be really helpful. I think it's an ego blow to have a colleague tell us that we're not performing, and so just recognizing that and being patient with that and being compassionate with that.
To add to what Tona said, I think it's also imperative to establish kind of some ground rules with your staff, that the expectation is right now that if we see something worrisome, we're just going to call it like we see it, and, you know, have a level of transparency and openness, and help that be part of the culture of the organization, I think makes a huge difference. Maria mentioned I'm the one who always says the thing everybody's thinking and nobody wants to say. And, I know that the culture with my staff, the expectation is that we give each other really candid feedback, particularly as it relates to how we're interacting with one another, because that's paramount in the work we do. And I think putting it out there explicitly and saying, hey, we know everybody's under a lot of stress, and if we start seeing signs of that, we're gonna bring it up and bring it to one another's attention, helps blunt that when that sort of very direct feedback has to be provided.
That's a great approach.
One thing I'll chime in and add with, kind of from my perspective is, and we didn't highlight it a lot, but leadership modeling and buy-in and support of all these things is like absolutely essential. And I don't just mean like I say it's important, I bring it up in the meeting. I mean, you actually have to model the behavior. And I'll give you an example from my own response experience. It's a different environment, right? But I've been on multiple disasters, working in multiple teams, and I've said, okay, watch your work-rest ratios. I want you taking lunch. I want to make sure you're eating, get your water. And the teams aren't doing that, right? And after a couple of days, like, I'm really frustrated about it. And it's like, why not? Well, you haven't taken a lunch. I'm getting emails from you at 8 o'clock, right? So it's like, I know what you're saying, but people learn from what you do. So the other thing I'd say too is having that leadership model the behavior, I think can also subtly help people really buy into the concept that like, this is a key operational strategy to make sure we're able to deliver our services. So it kind of sidesteps that question, but I also think it's kind of bundled into getting people to realize how important this is, not only as individuals, but as an organization to achieve our mission.
Thank you for that.
There's a question in the Q&A box. Someone is wondering if anyone has insights about how many of us are doing estate planning and end-of-life care plans and thinking about healthcare proxy and POA appointment. It seems necessary work to help assure the future of our families, but against the backdrop of COVID, it is a bit depressing, although getting things handled can ease anxiety. Is that a conversation, Dr. Tony or Wendy, that you're having with your staff, or is it something that people are aware of or thinking about, or has it been brought up?
Yeah, I want to make sure I get to the heart of the question, but certainly end-of-life care is a routine part of our conversations. And for at-risk individuals in the age of COVID, I think certainly in hotspots where there might be limited resources, I think it's actually really important in that context to have those conversations as well. It's part of the the triage and some of the tough decisions that are made. So absolutely, I think that, as a routine part of care, but then highlighted in the age of COVID, those are really important. You want to make sure the protocols are in place, and that there's also consistency in communication amongst, providers and among the staff on how those issues are approached.
The person clarified she's actually wondering more about staff, this issue, thinking about staff thinking about their end of life.
That's interesting. I think that, most of the people that I work with are young and not at risk, and I don't know that we would necessarily need to. I think that if you're full code, if everything's going to be done, you don't really change a lot of those approaches. You should still, have power of attorney and living will, so that your decisions are honored under certain circumstances. It had never honestly occurred to me to do like a facility-wide discussion like that. Perhaps something to think about. I'm not sure.
I'd second that. And what I'll add is that as a geriatric mental health specialist, any chance I get to tell people that everyone of all ages should have their advanced directives and their last will and testament complete. We all need those documents because none of us know if a bad thing's going to happen now or later. So that's not something we're really hearing from our staff. And my staff is actually really divided. I have young staff, and then a lot of people come to our community to work their last few years towards retirement. So we also have quite a number of staff who are later in life and at higher risk. But we offer an EAP, and if your organization doesn't offer an EAP that also has some legal supports behind it, it's a really, really inexpensive benefit to offer your staff. And we are encouraging people to reach out to their EAP for all sorts of things right now.
Thank you for that, Wendy. So we've just hit 1 o'clock and we want to be cognizant of everyone's busy schedules and competing priorities. So just once again, thank you all for joining us in this conversation today. Maria and I will be sending out the resources that Trevor shared and some links, as well as our contact information. Should you have any additional questions or would like to continue this conversation, please do feel free to reach out. And as we will also be sending a recording of the webinar. So thank you all for joining us today and have a wonderful Wednesday. Thank you.
Bye.
Take care, thanks.